Morning, everybody. Dr. Gillard here. Let's do some CVPP, shall we? Cardiovascular pathology. We haven't got to pulmonary yet. It is Thursday. It's week 3, and we're finishing up week 3. Looks like our online learning has been extended to May 15th, which is not unexpected at all. In fact, I wouldn't be surprised if this goes for the rest of the quarter. All right, here we go. What are we talking about? Oh, PAD. Very common problem. Let's talk about it. PAD stands for peripheral artery disease. Rubins and Robbins both call it that. There's a whole bunch of AKAs for PAD, unfortunately. So probably one of the most common ones that other authors use is peripheral vascular disease. That's PAD. Aortoiliac disease. That's PAD. And peripheral occlusive disease. Arterial sclerosis obliterans. So I would know, don't worry about these others. I mean, you could probably figure the rest of these out. But you should know the ones in red. Right? I can see the question. Blank, all of the following are AKAs for the term peripheral arterial disease, except for blank. And then I'd go through these aortoiliac. Yeah, and I can put a fake one in there. See, we're talking about how do you control all this information I'm giving to you? What do you study? I told a group this morning, you study the ones with tons of stars. These don't have tons of stars. But the other thing to think of is, think of professors. Anytime I see a slide that's got choices like this, it's really easy to make a question like the one I just told you. So that might be worth studying. Okay, PAD, peripheral artery, what is it? So it's progressive, but it's a clogging of the pipes. It's a clogging of the pipes. It's a progressive occlusive arterial disease. It's not in the veins, just the arteries. And the pipes clog up usually with atherosclerosis. So really, I won't say it's an AK because there are some other conditions that can cause it, but it's usually atherosclerosis that causes this disease. And the distal ilium is affected. The iliac arteries are affected. And even the common femoral occasionally gets to the popliteal, but it usually doesn't go past the femoral artery. So unlike Berger's disease, which only attacks the medium-sized arteries, so you can kind of, by taking the femoral pulse, the popliteal pulse, you can possibly tell the difference if they have if their dorsalis pedis is absent, and you start working your way up to figure out, well, where's the pipe clogged at? You can sometimes tell the difference between these. Therefore, it targets large and medium-sized arteries. And the posterior tibial, those guys are kind of medium to small arteries. I guess small arteries would be better. Pathophysiology, as I said, it's secondary to atherosclerosis. But really, it could be from the parent category of atherosclerosis, which is arteriosclerosis. Arteriosclerosis. Remember from your pathology days, arterial sclerosis has 3 subcategories, each of which has different pathological appearance. There's atherosclerosis, which you know. There's arteriolosclerosis. See the second O? Arteriolosclerosis. That's one of the 3 children under the main category of, I got that messed up, don't I? Arterial, I guess I didn't say this yet, but arteriosclerosis is the main category. This is atherosclerosis. That's another child. And Monkberg's medial sclerosis. Those are the 3 children. They're under the category, let's see if I could spell it right, of arteriosclerosis. Arterio. And then sclerosis. I'm writing with my finger. I don't have one of those pens that you guys have. SCLER. Osis. That's the parent category. And underneath the parent, the three children are atherosclerosis, Monkberg's medial sclerosis, and arteriolo. Guess what? And I won't go into the diseases right now, but guess what vessels are affected in arteriolosclerosis, which, by the way, is the most common of all of these things. The most common cause of blood pressure is arterial sclerosis. Arterioles, so this affects only the arterioles. Okay? So hopefully you remember that from back in the day. If you don't, that's some good basic pathology. All right, because of peripheral artery disease, because the favorite targets are, why does it say because? So just the favorite targets are the abdominal aorta. Oh, I see. Because the favorite targets are abdominal aorta and iliac arteries, this is why one of the AKAs is arterioiliac disease. I see what I'm trying to say there. What's going on here in this? There's abdominal aorta. Okay, there's the renal artery takeoffs. Yeah, so this is PAD, peripheral arterial disease. Look at how smashed that is from the process of atherosclerosis and arterial sclerosis in general. Maybe it's, but you can't call this arteriolosclerosis because this is the big artery. Arteriolosclerosis only affects the small arterioles. Right? Could be Monkberg's mixed in. Monkberg's and atherosclerosis are often mixed together. You ever seen a lateral x-ray of the lumbar spine and seen the abdominal aorta calcified, lit up? Why is it lit up? Because they have Monkberg's medial sclerosis. It's a calcific disease where it calcifies the tunica media. Remember that stuff from, who was that teaches that? Cooperstein probably? Anyway, the sequelae of PAD, it's progressive, so as the atherosclerosis gets worse and worse, the downstream beaver dam effect gets worse, and the downstream flow, as the beaver dam gets more complete, less and less water flows, and your legs start becoming ischemic. So it results in a slow, progressive, downstream tissue ischemia and all of its sequelae. So first thing, I'll probably say this like 3 times today. First thing that happens as the decrease of blood flow to the lower extremities occurs, the first thing the patient knows is something called claudication. I'm sure we've went over that somewhere. I can't remember. I'm talking about that in first quarter now too. But claudication is a pain, numbness, or weakness. Like the most typical thing I hear from patients is it's it feels like my legs I'm walking in cement. They don't have any power anymore. And it can hurt too, but it's usually that they don't have power and it's like they don't work. That's an intermittent claudication. And after they might have pain in their legs from that because the muscles are exercising and the beaver dam won't let it increase. We need increased blood to those exercising muscles, right? Where are they going to get that from if there's a beaver dam in the abdominal aorta? They don't get it, and they start becoming ischemic, and they start hurting and stop working. But after you stop and rest for a little bit, they catch up, and you can walk a little further. But as it gets worse, you start getting pain associated with it, and then the pain may last the whole next day or the next 3 days. And as it gets worse, pretty soon you have claudication just from walking around the house. And then pretty soon you start getting ulcers showing up or erythema or problems showing up in the extremities from tissue death, and if you don't do something about it, becomes gangrenous like this toe in a person with PAD. The other foot looked exactly the same. And so, yeah, why is this occurring? Because he doesn't have enough blood flow to his foot, and the tissue is dying, and particularly his second toe here, or his, what is that? Your second digit, I could say safely. All right. If arteries majorly affected, it would worsen hypertension. So if it's a big region, if it goes from your entire abdominal aorta to your common iliac and even down into your external iliac on both sides, that's enough where the heart has to actually start pumping harder to get blood through, because the heart senses the tissue down in the lower extremities needs oxygen, so the heart will start muscling up. So it can be a cause of hypertension as well if it's widespread. 55-year-old presents with complaints of intermittent claudication. So she walks 4 blocks and her legs cramp up and feel weak, and they have some leg pain as well. Usually if the pain lingers for a few days, they actually have pain while they're walking. So then it feels better after it takes NSAIDs and feels better. The pain feels particularly good if she puts her lower extremities in a position of dependence. What does that mean, position of dependence? Well, that's if you guys are sitting right now or standing, your lower extremities are in a position of dependence. Therefore, gravity is assisting the blood flowing, the arterial blood from flowing down into the legs, which is great. Although it's hindering blood from getting out of the legs, nevertheless, the tissue doesn't care as long as it gets some oxygenated blood. So you did a test called Berger's test, which we'll talk about next week, I believe. Yep, next week, I think. And she had a positive bilateral Berger's test. Berger's test, think PAD. And specifically, when you lifted her legs up to 45 degrees, I'm using 60 degrees now, 60 for 60 seconds. But the feet turned ghostly white because she's not getting enough blood flow. And then slowly returned to color when you sat her up and put her in a position of dependence. But it was a delayed return to color. Should return to color within 5-10 seconds. All right. You did an ankle brachial index test on them, and they scored a 0.78. That's terrible. That's the sensitivity or the specificity of that is about 98%. They have PAD, or they have something clogging the pipes. Maybe it's a big tumor compressing the abdominal aorta, but there's something clogging the pipes in the abdominal aorta. In order to have this in both lower extremities, it's got to be the aorta that's affected. Just to make sure, you order a 3D reconstruction. And what do you see here? That's pretty bad, right? This is the abdominal aorta. Here's the renal artery takeoffs here. Patient also has hypertension, I could have said. Because see the fill defect there, one of the kidneys is getting or is that superior? That looks like superior mesenteric. But the point of the story is, notice how it gets more narrow and narrow and narrow. And when it gets down to the common iliac arteries, it's way too narrow. In fact, the internals, here's the internal, that one, you can't even see the other one. So the gunk, these are all clogged up with gunk, and there's the lumen is very, very small where blood is flowing through. Yep, everything I just said, common iliacs, femoral, severely narrow because of atherosclerotic plaque, and yep, understand that. How about some other causes? So it's usually atherosclerosis and maybe some Monkberg's mixed in there. There's another condition. Arteriolosclerosis will never cause it because that only affects the arterioles. I heard somebody thinking that. But no. That's why you can't say the cause is arterial sclerosis. You have to say that's the main member. That's the heading. You have to say it's 2 of the children that could cause it, atherosclerosis or Monkberg's, not arteriolosclerosis. But there is another condition called fibromuscular dysplasia that we should talk about. And it's pretty simple. The tunica media gets really thick and full of scar tissue, so thick that it actually narrows the lumen, so you have decreased blood flow. And it also weakens the wall, and these people have aneurysms, and they could even rupture. So from Rubins and Robbins, they did a pretty good job on this. So it's rare, but it's more common than Marfan's, 0.4% prevalence. Marfan's is 0.01% of the population. And here's where I get you, the question I get you. It's non-inflammatory. Non-inflammatory. That's not true of atherosclerosis. It's considered an inflammatory disease. This is non-inflammatory. So it has nothing to do with any of the members under the arteriosclerosis. Oh, here's the subcategories. Arteriosclerosis is the main category. So now it's in stone. I can ask it. Remember, I only ask you questions that come from slides. If I start rambling, maybe you need to know it for boards or whatever, but I'm not going to ask you a question unless I can find it on a slide. But there's the family members: atherosclerosis, arterial sclerosis, and Monkbarg's sclerosis. But the etiology of fibromuscular dysplasia is really unknown. There's some genetic familial tendencies with it. If your parents have it, family members have it, your chance of having it increases. Typically likes females under the age of 40, so it occurs during the reproductive years. There's some theories about some hormones, progesterone and estrogens and things like that. No solid proof though. But yeah, the smooth muscle is replaced by a fibrous tissue, which is weird because usually we see fibroblasts as part of an inflammation or inflammatory process. I always talk about later today I'll talk about a fibroblast heavy inflammation. But here we have a fibrous tissue laid down without an inflammation, which is quite strange. But that's what happens. The smooth muscle becomes really filled with scar tissue or fibrous tissue. Right? In other words, tunica media and sometimes the tunica intima can move down into the intima. They become hyperplastic and fibrotic. Okay, where does the fibromuscular dysplasia usually attack? So this one loves the renal arteries. In fact, it's a common cause of secondary hypertension behind, I want to say it's right behind hyperaldosteronism or the R2A. It's right behind the renal artery getting, for whatever, low blood pressure, a beaver dam in the renal artery, or whatever the cause, turning on the R2A system. Yeah, renal artery stenosis, from whatever reason, is the most common cause of secondary hypertension. This is probably the second. So 65% of the time it hits the renal artery. And if it hits the renal artery, if it narrows the pipe to the renal artery, the juxtaglomerular system turns on and renin's secreted, and you know the rest of the story. And let's see, carotid and vertebral arteries can be affected, so this could cause some cerebral problems, some dizziness. If the vertebral arteries are affected, cerebellum gets hit. Carotid arteries, your whole noodle gets hit, so not good. Splanchnic arteries, the external iliac arteries. So it can definitely be a cause of PAD, because that's PAD territory. External iliacs are PAD territory. Okay, stenosis can get so bad that the beaver dams are created, and it creates PAD, peripheral arterial disease. Can cause hypertension if it does get into the aorta, which it can. It could cause some hypertension. Could cause a small bowel infarct if it gets into the superior mesenteric artery, which it does like. Right? Remember all those intestinal arteries? It can cause a beaver dam, and you can get an infarct of the small bowel. If it happens up in the noodle or up in the vertebral arteries or carotid arteries, you can get a TIA from lack of blood flow, or maybe even a real stroke if it completely narrows. And as I said before, it weakens the blood vessels and does increase the risk for aneurysm and hemorrhage as well. All right, everybody good about fibromuscular dysplasia? We're out of that rabbit hole. What's the prevalence of PAD anyway? It's a big number, right? But 3% of the population has this, and it's probably much higher because most people are asymptomatic. So I would say it's probably up around 10% or so. And you don't detect PAD until you start having claudication and have to go to the doc. And risk factors are pretty much the same ones that increase the risk of all heart disease. So smoking, diabetes, hypertension, hyperlipidemia, hypercholesterolemia, hypercoagulable state. All that stuff is a risk factor for PAD. PAD versus smoking. All research, smoking is particular. You want to get PAD, smoke really heavily. You get Berger's disease or PAD or one of the, or both of them. So it's the single most important risk factor for making the diagnosis of PAD. There's a dose relationship, so the more pack years someone has smoked, the greater chances they have of developing PAD. Strongly associated with PAD, more so even than coronary artery disease. Smoking, of course, is, you want to get wrinkles, smoke heavily. Smoking cessation, though, may in some cases decrease the progression of the PAD. It's not going to fix it. So it's never too late to stop. It might at least help it from turning into gangrene and you losing your feet over it. Vascular, and we've said this already once. Here's the second time I'll say it. Vascular intermittent claudication is usually the first sign of PAD. You used to be able to walk a mile with your wife or 2 miles with your partner, and God, this year snow clears away and you go for your first walk and you're like, gosh, my legs feel weird, like they hurt, or they don't feel like they're working, or it feels like they don't have power. It feels like I'm walking through cement. All those feelings. But you can still go for a mile and you struggle. Then winter comes. And the next season comes and you're like, God, I can't even walk more than 2 blocks now. You better go to the doc, because something's either clogging the pipes. You either have vascular intermittent claudication, VIC, or NIC. Because neurogenic intermittent claudication from central spinal stenosis can do exactly the same thing. And it's really hard to tell the two apart. Okay, and one can kill you. One can vascular, if you have that much atherosclerosis clogging that pipe, it's probably in your coronary arteries and in carotid arteries as well. That needs to be worked up. The spinal stenosis, it can make your life miserable. It's probably not going to, it's not going to kill you. It can make your life miserable though. So after that, but if you're not walking, you're okay. But pretty soon, not just walking around the house and doing yard work. I call it activities of daily living claudication. I should have put claudication in there. But you get pain in your legs from that. And then pretty soon, you're starting to get some changes in the skin. Skin's actually starting to die. So you're getting ulcerations. And then it can go to gangrene. So that's kind of the progression. Let me make a note to change that slide. 391. I want to add claudication pain there. Right. More natural history. So for people who have reached the point where the tissue is dying and becoming gangrenous, that has a word. That's called critical limb ischemia. You will see the doctor or you will die from gangrene. And for those who have reached that phase where severe ulcers occur, that's usually enough to make the diagnosis of critical limb ischemia, or heaven forbid, gangrene definitely makes the diagnosis of the end phase of PAD, critical limb ischemia. There's some research. And how are these people doing 1 year after that diagnosis, people who are treated? Well, about 25%. It's split about 25% into 4 possible outcomes. 25% of the people, they will improve with treatment, whether it's a sympathectomy or whatever. Or we'll look at the treatments for it in a bit. You can bypass the dead aorta with Darcon graft if you want, but we'll look at those. Endarterectomy. 30% of them actually, they fail treatment. They need an amputation to save their life, and then they have to still get the endarterectomy because the other foot might be affected. But they're alive. 20% they struggle with ischemia. They're not out of the woods yet. The treatment's like kind of holding it off, but they're about the same. And then 25% flat out die. That's a huge number, right? This is a horrible diagnosis, critical limb ischemia. They die of other, usually heart, cardiovascular related diseases. So that's interesting research. There's the original study there, and that still holds today. Right? PAD, there's a patient with PAD who has definitely reached the end stage of PAD, which is critical limb ischemia, and he is awaiting I think it's a she actually. She's awaiting amputation. How about some relationships? Impotency, very common in people who have PAD, which is maybe not even symptomatic. Maybe the first sign of it is impotency, can't get an erection anymore, or it kind of works, but it doesn't stay erect very long. It's not as hard as it used to be. It's softer. And then that can get to the point where it doesn't even work anymore. And the key is we probably won't get into this, but the key with impotency, these people still have the desire, but they can't, the plumbing doesn't allow them, it doesn't work. They can't get an erection, or not a strong enough erection. That old people, as you get older, for reasons we don't understand, and it's not all about testosterone, they lose their desire to have sex. And so you have to be careful between impotency versus just they've lost the desire. But anyway, 40% of people, men with PAD, also have complaints, so almost half. And you can imagine men don't like to tell their doctor about that, so I bet it's probably 60%. So it's a very common problem because they have gunk clogging up their aorta. They probably got gunk clogging up their internal iliac, which supplies the pudendal artery. And yeah, that's one of the main supplies of the penis. I wonder if that should be external pudendal artery. Let me make a note of that one to check that. I'll leave it like that for now, but I'll correct it on the slides I post if that's an error. My brain says external. Anyway, yeah, so the corpus cavernosa and spongiosum can't be filled up with blood if there's no supply to it. If the pipes going to that tissue doesn't work, then you can't get an erection because you can't fill up the corpus cavernosum or corpus spongiosum. And again, men, they have the desire, but it just doesn't work. So got to think PAD. What's your job? Your job is to do an ankle brachial index test and to know, if you don't want to do that, fine, but know if they have claudication. You need to work up that claudication. Is it Nick or Vic? So you can order a MRI to see if they have central stenosis. If they don't have central stenosis, you better refer them to the vascular surgeon. That's part of your duties as a primary healthcare provider, to know stuff like that. So I didn't throw a lot of stars here, but this is all really important stuff, right? So I would definitely know this, the difference between Vic and Nick. For treatment of critical limb ischemia, so about 50% of them eventually have to go some type of revascularization procedure. That's the fancy way of saying you need to open the pipes back up so the blood can flow. They won't say that on the boards. They'll say revascularization, but that's what it means. Open up the pipes, scrape the gunk out or bypass it, and that's exactly what they do. There's two procedures. The gold standard is the aortoiliac bypass surgery, and they literally take a new tube of Darkon graft, which is, it's a tube. It's literally a tube, and they stick the tube, and there's different shapes of it, but they just, I'll show you a picture in a minute, but they just stick the new tube in over the gunked up dysfunctional portion of the artery. And there's, some of the Darkon is shaped like the common carotid arteries, like that, so you can bypass. I'll show you a picture in a second. All right, that's the gold standard. There is another one that they used to do, and they still do it, but Darkon is by far the gold standard. You can open up the aorta. You can clamp it off. You can reroute the blood. And, you're just going to go, you have to work fast. If you clamp off the aorta, you can't, you're not going to be supplying the lower extremities. So you can, and there's some collateral circulation, I guess, that will, little tiny vessels that will help it. But you got to work fast. But you can clamp off the aorta, slice open the aorta, and literally pull all that gunk out of the lumen. I'll show you a picture of that gunk. It literally looks like the stuff that clogs up your drain. All right, so here's an endarterectomy, and they've clamped it off, and they're just finishing sewing the abdominal aorta up. They've butterflied that thing right open, and they've cleaned out the crud, and now they're sewing it back up, and then they're going to unclamp it. It's out of the view up here. They'll open up the clamp, and hopefully it's fixed. Here is, believe it or not, this is the gunk that they pulled out of that artery. That's not the artery. That's the stuff that was plugging in. The blood was barely getting through. It's all a combination of atherosclerosis, and there's some fat in there, and it's just pretty gross. But yeah, there it is. And there's some calcium in there, and yeah. All right, the aortoiliac bypass is the good Darkon. Use that Darkon tube. And depending on where it is, in this patient, most of the problem was the common femoral arteries, or the common iliac arteries here. And so they sewed it in here, and they shut off the blood here. They don't show that, but they have to. You don't want any blood flowing through that. But I guess you could you leave blood flowing through? I think they actually shut it out. But you could let blood flow through that if there's some trickle. I don't think they cut that right out. I haven't dig that deep into the procedure, but I guess that makes me wonder if you clamp that off, that tissue's going to die, and you can't have that and cause an inflammation. So they must take it out or just let it trickle the blood that it usually does. If it's beaver dam here, the blood's just going to go flowing through here. I bet they just leave it there. I'll have to check that. But anyway, there it is. They just bypass it, and most of the blood goes through this nice Darcon tube. And that's the gold standard. All right, we're moving. Of course, I have no idea what time it is. I should have looked at my watch, but I think we're ahead of schedule today. So now let's talk about one more thing today, and that's it. Raynaud's phenomenon. We have one rabbit hole to fall down as well. So some of you might wonder, I bet one person, usually every other quarter, somebody has this. It's probably going to be female. It probably started when you're a teenager. And let's talk about Raynaud's phenomenon. Very common. Well, not very common, but it's way more prevalent than Marfan syndrome. So what is it? It's the pipes. Nothing clogs the pipes up. But all of a sudden, the tunica media goes crazy in the small arteries and arterioles of the fingers or toes usually. It goes crazy and it completely narrows those vessels down, and you get a downstream ischemia because of that. So let's draw a little artery here. I'm magnifying, of course. This is way too big. Here's a digital artery. Okay, and then all of a sudden, out of the blue, for reasons we don't understand, the tunica medias go crazy, and they vasoconstrict. And now it's completely shut off. So there's no blood flow. I guess I should use a different color, huh? We'll say this is Mr. Spock. He has green blood, right? So the blood is trying to go through, can't anymore. So what happens? If you don't have blood, what happens to your skin? Step 1 becomes, what's that called? Pyloric. Step 2. This one happened first. It becomes cyanotic, right? But luckily, the spasm releases and the blood flows after the spasm releases. But then so this is painful, right? We've all had our hands fall asleep a little bit, and it stings and tingles. If you look at your fingers, they're not white. You can imagine this is worse than falling asleep because you literally cut off the blood. It can be quite painful. But after the blood vessels open back up again, let's use this one here. So after the blood vessels are happy and they open back up again, so what does this tissue, let's back up, what does this tissue do when it's ischemic? The endothelial cells freak and they secrete nitric oxide. So nitric oxide is backing up like crazy. It doesn't work, but once the artery pops open again and blood comes flying into the finger like full blast, so what happens to the finger then? Well, all that excess nitric oxide comes flying in here as well. And that over vasodilates these little tiny microcirculation here, and this whole thing turns red, and now it hurts. It throbs as the blood comes pounding in here because of all that nitric oxide. Okay, so that's kind of the two stages of how Raynaud's work. And then after a while, it settles down and you're back to normal again. And you may go for another 6 months and never have attack. You may go for, if it's the winter time, you may go next month. It may happen again. Or maybe next week, or maybe in a couple of days. Everybody has it, the disease, to different degrees. But key with this slide, always the small arteries hit, or the arterioles. It's not the it's not the medium arteries or anything else like that. It's almost always the hands. It can affect the feet. Rarely it can hit the lymph nodes in the nose and the lips, but that's pretty darn rare. Never seen anybody like that. except pictures. So everything I just said, the attack of downstream ischemia is typically temporary. However, during the attack, the affected tissue gets very painful. After the vasospasm, the artery pops back open to normal size, blood flow returns, then you get a throbbing pain as that blood flow comes flying in there. And there's too much vasodilation because of all the nitric oxide and other vasodilators that released. Clinically, the patients typically present first with pallor and then cyanosis, as we saw. And then after the relaxation occurs, they become erythemic and throbbing pain at that point. Okay, clinically speaking, so some authors describe this as paradoxical attacks because they can happen out of the blue. We'll see cold and extreme cold and stress can trigger these attacks, but sometimes you can just be sitting there in class and bam, it happens for no reason at all. So therefore, it's described as a paroxysmal attack. Of finger pain and paresthesia and color change and such. Typically, these attacks can last for minutes to hours, depending on how long it stays clamped for. But it usually doesn't cause any permanent damage. Usually. That's not always the case, though. People with severe chronic Raynaud's, it can damage vessels if it happens a lot, but that's rare. Usually it's no big deal. It happens bilaterally. Did I say that somewhere? Did I miss that? It happens bilaterally, unlike secondary Raynaud's. We're really talking about primary Raynaud's right now, I should add. But yes, cold, strong emotion are the two biggest triggers. Catecholamine release, anything that gets the sympathetics turned on can do it as well. Mild heat can bring relief to it if you're in one of these spasms. Not too much, not super hot, because that'll make it throb worse. And sometimes super cold outside and you wear gloves and you try to protect yourself, and here's a patient out walking around, and all of a sudden they get pain in their fingers, they pull off their gloves, and sure enough, we have different stages. This one is still vasoconstricted, just starting. This digit artery has already opened up. So you can see you have different phases going on in the same hand. Really weird, right? What a strange condition. There's comorbidities associated, although Raynaud's, primary Raynaud's, I should change that. I'm going to write that down too. I say that every quarter, but now at least I can write stuff down. Primary Raynaud's. So it doesn't interfere with your lifespan. But there are some other comorbidities that could affect your lifespan, like pulmonary hypertension. Some people believe that there's an oversecretion of endothelin that goes on in the microcirculation of the lungs. That's one of the proposed theories. We don't know what causes Raynaud's, the vasospasm, but one is an overproduction of endothelin in the hand. So same thing can happen in the lungs and give you a pulmonary hypertension. It can give you unexplained angina or even a heart attack. If you have Raynaud's, primary Raynaud's that we talked about, there is an increased chance that you could have Raynaud's of the heart, you can think of it as, even though they don't call it that. But that's what it is. It's called coronary artery vasospasm. And I took all the gunk out because I'm trying to get through more slides, but I just condensed it down to one slide. So it's controversial and it's not well studied. Some of the research shows the prevalence is found in about 7% of people with heart disease and angina. They go in to get an angiogram or angioplasty. They do an angiogram to see where the clog is, which coronary artery is clogged, and lo and behold, the coronary arteries are wide open. That happens in about 7% of people who they think their chest pain, their angina, is pre-heart attack from atherosclerosis, and it's not. So the theory is it's coronary artery vasospasm. They can't see it happen. That's why it's kind of controversial. But a fact, about 7% of Caucasians with angina going in for angioplasty, they fail. The angiogram fails to show any type of occlusion. So we're learning a lot more about this. People with Japanese ancestry, or who are Japanese, 20% in them. So they're the worst out of all the different types of populations to be affected by this. And it's just, there's kind of a couple ways that it can happen. There's mini attacks of cardiac ischemia, they believe. And again, they can't see this, so this is all theory. But they believe, just like Raynaud's, you get mini attacks of coronary ischemia over and over and over. And after many years, all that ischemia damages the heart, and you start to get heart failure. Or then it causes angina for weeks or months or years, and then all of a sudden you have a real heart attack and die, and they do the autopsy and think they're going to find the coronary arteries clogged up with gunk, and there's nothing. They're beautiful. And that's listed as the death as a myocardial infarction, probably secondary to coronary artery vasospasm. Or maybe there was an embolism, but they don't find it. So it's kind of a scary thing, but we just don't know enough about it to really talk that much about it. The board books don't talk that much about it. They call it some funky thing that's not even, I won't get into that, but Robbins makes some new name up for it that's not even in PubMed, which is ridiculous. Come on, Robbins. Anyway, what we already talked about this. What causes the red, white, and blue? So it's the different stages of vasospasm. So as we saw in the guy who took off the glove, you can have one digital artery in full vasospasm. You can be white or blue. You can have one in full kind of recuperatory where you don't have vasospasm. You have vasodilation, too much vasodilation, and they're red and they're throbbing in there. So it can present like that in different ways. Just a easy slides, lots of stars there. Easy question for me. So white, why do people get white color? Well, that's pallor. That's the initial vasospasm is happening. Why do they get blue? That's toward the end of the vasospasm. They get cyanotic because the tissue is really starting to have trouble. Why do they get red? The vasospasm has released, and now they're over vasodilated. They have erythema. So, easy question there. Can't miss easy questions like that. All right. Here's the guy, pretty even here. So he's just starting the... Actually, this one looks like it's affecting the entire hands because look at his skin color here. So different blood vessels in different states. Here, the same thing. You can see the red, the white, and the blue started up here. So it's really, really weird. So the digital artery here might be going through one phase, and it might start up here in a second phase. So you can have it. You can have 3 different vasospasms in 3 different stages of recovery in one finger. So pretty weird stuff. There's 2 different types of Raynaud's disease, as I've mentioned. We've been talking about primary Raynaud's disease. Or I guess, they split hairs. Raynaud's phenomenon. There's 2 types of. There's a primary Raynaud's phenomenon and a secondary Raynaud's phenomenon. I've just been calling it Raynaud's disease. That's an AKA for Raynaud's phenomenon. They're trying to split it into 2 parts now. So we haven't talked about secondary Raynaud's. So let's talk about that one because we're going to fall down a rabbit hole in this one. Primary Raynaud's phenomenon is the one we've triggered by cold and emotion. Look at the prevalence in this, 11% in women. So about 10% in humans. That's a huge number. People affected by this various degrees. And that's bad enough to go in to see a doctor's. Primary affects young women. We already talked about this, didn't we? Affects young women, starts in the late teens, second decade of life, typically bilaterally. It's symmetrical. Usually both hands are affected about the same way. Not true. None of this is true for secondary Raynaud's. It's usually unilaterally. And it's a progressive disease, as we'll see. The condition doesn't usually worsen with time, although in more severe cases it can cause some damage after 30 years of having this over and over. Usually strikes in the exact same location every time with the same magnitude of pain, which is not true of the secondary Raynaud's or even Berger's disease. Those are both progressive disease, progressive disorders. The etiology is unknown. Again, the current research points the finger at an overproduction of endothelin and an underproduction of nitric oxide. Probably you don't have genes that are producing enough nitric oxide, and you have hyperactive genes that are expressing endothelin where they shouldn't be expressing endothelin. Remember, that's only for bleeding, severe drops in blood pressure. Does that supposed to be turned on? And of course, the endothelin causes tunica medius vasospasm. Right, so here's a patient suffering temporary, it's just Raynaud's. Just another picture. Here's a more rare one. So here's on the bottom of his feet. Notice they're both, see how they're symmetrical, both feet affected at the same time, and they're both in approximately the same degree of stage of the vasospasm. Here's a rare one. Cheek on the chin. Never even seen it on the cheek until he stumbled onto this picture. So it does happen in other places as well. Okay, secondary Raynaud's is no bueno. It could be fatal. It could be the sign of a fatal disease happening. And there's no relation. The people who have primary Raynaud's, they're not going to get systemic sclerosis or things like that. There's no relation to that. But if you do have a unilateral Raynaud's, that's a little more concerning. Maybe that's an early secondary, because this is usually unilateral disease. But it is associated with some problems. Systemic lupus can kill you. Rheumatoid arthritis can't kill you, but it can make you well, it could kill you if you're in a car accident and it's loosened up your transverse ligament of atlas and you couldn't tolerate a whiplash. You'd be paralyzed. Systemic sclerosis, though. So some bad diseases here. And so someone who starts up in the blue 40s, they get Raynaud's in one hand, you got to work them up for these diseases to make sure that's not the real diagnosis. Scleroderma, I've learned you know nothing of scleroderma. So let's go through scleroderma. And Robbins does a pretty good job in this. So I call it I learned it as scleroderma. It's hard for me to call it systemic sclerosis, but it's another one they're trying to change the names. Like the peroneal artery, they're trying to change that to fibular artery. And what is it? Netters doesn't even say peroneal anymore. But yeah, it's another one of those changes. But strong AKA scleroderma. And the prevalence is rare, same as Marfan's, but it's out there. And 3 signs of development of systemic sclerosis. One is you have these inflammations, fibroblast heavy inflammations, I could add, that happen on the skin secondary to a immune attack. I have a slide coming on that. And widespread inflammatory damage to small blood vessels. And so because of this damage, you get these little mini varicose veins. It's called telangiectasia. We have a slide on that. But damage to the skin, damage to the small blood vessels, and then you get a fibroblast heavy inflammation that affects your skin, your heart, your liver. It can be everywhere if it progresses. One type just stays to the skin, thank goodness. It can be quite disfiguring. But one type hits the organs, and that one can be fatal. It's got a bad prognosis. Other targets, so in addition to the cutaneous involvement, I already said this, your organs could get hit. Your GI tract, kidneys, heart, muscle, lungs, especially your lungs can get hit. It's not a great diagnosis. In the majority of patients, it can lead to death, although they can fight it and it can go for many years. But in some patients, it can stay in the skin for the rest of your life. But if you live long enough, I think it would always eventually get into the visceral organs. There's 2 subtypes of scleroderma, of course, or systemic sclerosis. The most deadly one, let's do that first. So this is called diffuse scleroderma. Let me take some water here. Okay. It's not as bad as esophageal cancer, but it's not great. 20% are going to be dead in 5 years with treatment. Much higher will be dead without treatment. But it's greatly improved with the treatment nowadays. And this one really hits the skin it hits the skin first, but then instead of hanging out on the skin like the other one does, it immediately dives in and starts getting the organs, especially the lungs. In fact, usually death is from when you get fibrosis in the lungs and you run out of oxygen, pulmonary arrest, and die from it. Here is a victim of diffuse scleroderma. And you can see this is all thick looking, and yeah, it's all full of scar tissue, all in the dermis layer. Here's the same patient. This is the least of her worries, though. It's a disfiguring, but she can't breathe. So you take an x-ray of her lungs, and if you've seen enough soft tissue films, this looks fine up here. There's the apices of the lungs. You have nice and clear. Photons are zipping through there, no problem. But look what happens as we get down to here. These lungs are shot. They don't work anymore. They're full of gunk, full of scar tissue, and that's fibrosis. They don't exchange oxygen, and so it's not a good death. Asbestosis can look very similar to this, by the way. All right. So the other type is called limited scleroderma. Why is it limited? Because it doesn't dive into the organs very good. It usually stays in the fingers. It loves the fingers and get these sausage-like fingers, forearms, and unfortunately hits the face. Mortality, it does dive into the organs, but not as rapidly as the other one. So it's about half less fatal as the other one. 5-year mortality rate's about 10%. These are still serious diseases, though. Did I turn on my backup? Yes, I did. I was just thinking of that. I got a backup camera filming my screen here just in case Camtasia flips out and loses the recording. If the visceral involvement occurs, it'll be usually later in life. These are the ones that you've heard of. We talked about in embryology about CREST syndrome. Did I have you guys? I can't remember if I had you guys or not in embryology. But we talked about CREST syndrome. And esophageal problems are in CREST syndrome as well. But this is another member of the CREST syndrome complex here. So let's take a look at that. So limited scleroderma, concomitant diseases, it's a member of CREST syndrome. So let's remember CREST. It's these people have calcification of tissue all over the body. You see it in the ribs, the costochondral cartilage loves to get calcified. It can happen in the brain. It can happen in the liver. It can happen in the heart. They just calcify all over the place. Raynaud's phenomenon, that's secondary Raynaud's is what we're talking about now. And esophageal dysmotility syndrome is a member of this as well. Sclerodactyly is a member of this, where you get fingers all scarred up. And yep, so people with limited scleroderma, they can get both sclerodactyly and they can get Raynaud's phenomenon. So they can get into this category of diseases two ways, because both of these can occur in people with limited scleroderma. And then they get this weird skin where the microcirculation just blows up because of the attack, the autoimmune attack. And it's like you have little varicose veins all over. That's called telangiectasia. If you have two or more of these symptoms, you get the extra diagnosis. Not only do you have limited scleroderma, you get the diagnosis of CREST syndrome as well. Actually, for people with limited scleroderma, you have to have 3, because Raynaud's and sclerodactyly are part of that family. So your chances of having or developing calcinosis or esophageal problems or telangiectasia are greatly increased. Here's run-of-the-mill telangiectasia. We've actually looked at this. This patient actually had a DVT a long time ago, and it caused He's a retail clerk. He's always standing up. He looks fine right now, but usually he's all swelling up. And the chronic venous stasis and hypertension in the microcirculation destroyed the blood vessels. And yeah, the telangiectasia. Patient with scleroderma might have this and they don't have any trouble. They could have this on their chest, on their arms, anywhere. But that's telangiectasia, a really good picture of it. What's the etiology? Again, it's not completely understood. We know it's an autoimmune attack against some antigen. We have not figured out the antigen. Remember, I talked about pemphigus vulgaris and bullous pemphigoid. Bullous pemphigoid, number one blistering disease of the skin. We know exactly who the antigen. It's that one BP230. There's probably one single protein somewhere on blood vessels. We haven't discovered it, but it's probably the same sort of deal. But nevertheless, we're getting an autoimmune attack against that target, whoever it may be. And not only it causes inflammation, but it causes a fibroblast-heavy inflammation. And fibroblasts, of course, their job is to spit out scar tissue and repair, but they spit out more scar tissue than repair things, and you get gunk and collagen deposited in the tissues. With regard to testing, antitest is usually positive on these patients, so your anti-nuclear antibody test. And these are antibodies that attack the nuclei of your own cells and destroy them. Let's look at some pictures. Here's a patient with limited scleroderma, and they have sclerodactyly, and and a little Raynaud's going on at the same time. Got a little skin change, color change, so little permanent Raynaud's. Remember, the secondary Raynaud's, it doesn't go away. It stays there all the time. Primary Raynaud's is just temporary attack and you're back to normal. So we got a little Raynaud's going on with sclerodactyly. I should add that. Got a lot to add on this one. Doing this one first thing in my morning when my brain is nice and had a good night's sleep. So staying ahead with these videos is, making 3 a day is too much. So if I can stay ahead one day, the week was much more enjoyable for me. The only down part is I have to work a little bit over the weekend and Friday, but that's okay. Okay. Here's another one, classic sausage fingers, patient with limited scleroderma, and they have sclerodactyly. I don't think I would call that Raynaud's associated. It's not a secondary Raynaud's there. And here is a patient with, I think they might have a little sclerodactyly. Look how swollen those up as well, but they have secondary Raynaud's as well. So they're definitely a member of CREST syndrome. They had something else to kick them in because it really has to be 3. All right, anyway, we're out of that rabbit hole. Secondary Raynaud's, I really just talked about it. Typically presents asymmetrically, as we said, not true of primary Raynaud's. Tends to progressively worsen. And remember, it starts out as a little whiteness like in that one picture. That's there. It doesn't go away. But it gets, pretty soon it'll start turning a little bit bluish looking. And it doesn't progress to the red stage because vasodilation never occurs. So tissue gets more and more destroyed as the beaver dam gets stronger and stronger and stronger. And eventually it ends up with gangrene and you have to amputate, right? He's prepped. He's ready for surgery, right? There's the surgical gauze he's on, and yep, you got to take these fingers off because they're becoming gangrenous. The yellow is betadine. That's prep for surgery to kill all the bugs. That's not part of the skin color. All right, aneurysms. Let's see. How many slides do we? That's probably enough for your brains, I think. That's like 35. That's like 60. That's enough slides. We'll start aneurysms fresh next week. All right. You guys have a great weekend. Again, email me your questions and have a great weekend.